didn't save on OneDrive last night, I don't know. So I'm using, these will be posted soon. After I go through them, but we're gonna, it basically has to bounce back between slides because my OneDrive didn't run. All right, so hirsutism is females, right, with excess androgens, testosterone being that primary driver. And that's what we're gonna just finish off with some questions related to that, right? Present with excess facial hair, oily skin, and some conditions might have menstrual cycle irregularities, and that goes a different route. And then there's red flags for cancer that we talked about, right? All right, so which of the following describes a key androgen laboratory the key androgen laboratory tests needed to evaluate a patient with a concerning etiology and rapid presentation of hirsutism? This is hard. There's one, I guess, which is the best answer, right? And then I look at the question, androgen laboratory tests for concerning a patient. This isn't just familial hirsutism. That helps. D? Okay. Anyone opposed to D? Oh, no. Right. Back here. Does it work? Okay. So, good job. D it is. Perfect. The free total testosterone, androsterone, and DHEAS, right? Those are our three go-to androgen labs, especially when we're concerned about cancer or something like that. Here's where I got it from. And then here's your explanation. Lipids, total T, and free T, and prolactin are really important when we're working someone up for PCOS. But again, it's not, you need those three cornerstone labs. So helpful, but not that androgen specific. Free T, testosterone, 21 hydroxylase, and TSH. Helpful. When do we ever order 21 hydroxylase? So remember that's the enzyme deficiency. So do we ever order that one? No, we're going to do the 17 hydroxyprogesterone. Remember that from the last test, you guys all got that right. This is my 100%. Question, you guys killed it. So I can't execute it. I won't. And then LH, FSH, TSH, free tool, helpful, but doesn't answer the question. And then the last one, helpful, but not. And then what condition you're concerned, do we order 17-hydroxyprogesterone? If we're worried about CAH, we're going to order anytime we're working someone up for PCOS. Because it's really only 2% of people will have that non-classic CAH, but it's easy to rule out with that. Which is the most common cause of hirsutism in women? Idiopathic, polycystic ovarian syndrome, congenital adrenal hyperplasia, ovarian tumor, or anabolic steroid use? Yeah. Women do mess around with testosterone, but not the most common. Yes, PCOS all day. And then here's why. And I have like a little questions like how is idiopathic or familial different than PCOS? Just to kind of get you guys thinking if you use these all the time. Okay, that is it for questions. New information, excuse me. 12, calcium regulating hormones. So we're taking a break from androgens. I realized last night that obesity actually sneaks into this lecture for one condition. So we'll talk about that in just once. But overall, it's relatively different than anything we've talked about in this class. But knowing what you're studying for in cards, calcium, right, plays a role in EKGs and things like that. So maybe a tiny bit of overlap with Dr. Ford, but I don't know why it worked. All right, hold on 1 second. I don't mind to just stand here. Aha! Okay, be smarter than me. Okay, so when we look at calcium regulation, it's organized as hypercalcemia, hypo, and then osteoporosis and osteopenia will end with. We need calcium, right? It's an essential mineral that we need for all sorts of things. You guys know the cardiovascular stuff, and we'll talk about other things too, but neurologically we need it, homeostasis in our blood, bones, right? Bone physiology, bone density, cell signaling, lots of things. It's important. 99% of our total blood calcium is sequestered in the bones. Okay, there's only 1% that's in the blood, and of course, just like we talked about with our steroids, there's free. In calcium terms, it's ionized, so your ionized is your free, and that's your active form of calcium, and then it's bound to other proteins. The most important protein is albumin. I don't get into that super deep, but know that albumin plays a role, especially when calcium is low. Okay, there's your ranges. It's a pretty tight range, right? 8.5 to 10.5. So when it's elevated, we can't just ignore it, okay? Because it's a tight range, and we want it in that nice little range intentionally. So if 99% of my calcium is in the bones, where am I going to get it if I need more? Calcium's low, feedback loop is stimulated, where's my body going to get it? Yeah, bones for sure. There's two other options too, but for sure bones. And then here's your very basic review. I know Mr. Weber has like a fun version of this, but again, this is our, this cycle's happening all the time with osteoclasts, osteoblasts. Right? As the osteoclasts do their thing, they're breaking down the bone. That's how calcium gets reabsorbed into the blood. And then osteoblasts build things up. Okay? So again, you'll see in diagrams will have a bone. This is what's happening and how we're getting it. Okay? It's not pathophysiology, it's not anatomy physiology, so I'm not going to test you on this, but it's kind of nice to have a record. So organs that regulate calcium, parathyroid gland, and the kidney. Where's our parathyroid? Yeah, there's 4 glands in the neck, right along with the thyroid, and then obviously the kidneys. Hormones that are important is our parathyroid hormone. We talk about that a lot. Vitamin D. I talked about that a little more than I did last semester. And then calcitonin is important. It's the opposite of parathyroid hormone. It's probably the hormone I talk about the least. I think the poor thing gets like 1 or 2 slides only. These are the hormones that regulate calcium. PTH or parathyroid being the primary driver, right? This is the major control over plasma concentration in the body. And when calcium goes down and we have calcium low, PTH is secreted. When calcium is too high, PTH levels decrease. Okay. Magnesium is a really important role. It usually mimics, it's similar, it mimics the role of what calcium does. So again, when magnesium goes low, it stimulates PTH to be released. When magnesium is high, it'll suppress it. There's the range. You don't have to memorize the range, and that's all to help you. Okay. This to me, you can read this, and that's your intro, but you know, I love a good feedback loop with photos, okay? So we have a drop. Before we do the loop, let's go. Yeah, there's a drop in calcium, okay? And that stimulates PTH to be released, right? We need to maintain homeostasis. So we're going to go to the bones. Those osteoclasts, osteoblasts are going to do their thing, and that's going to get or calcium into the blood. Okay, so there's one way. The other way is the kidneys. Okay, so PTH goes directly to the kidneys and the renal tubules. To be specific, it's going to stimulate reabsorption of calcium. I need to hold on to that calcium and do that through the kidneys to improve homeostasis, reach homeostasis. In addition, the reabsorption of calcium is also going to activate vitamin D. So this is the activation of vitamin D, happens by the kidneys primarily. And what that does is vitamin D goes and does its thing in the intestines to absorb calcium. So So you have 3 ways to absorb calcium when PTH is excreted. Directly on the bone and kidneys, and indirectly vitamin D in the intestines. Did you learn about this in farm maybe, or no, not okay. This I'll say it's not my least favorite, but it's the slide that I really want to simplify it so it makes sense. You guys always do really well on these questions, so that's why I slow down a little bit. All right, so we're going to talk about vitamin D. Vitamin D is a little annoying, but I have a lot on the slide intentionally because it gets confusing. I'll tell you what I care about, but we get vitamin D from supplements, right? It's fortified in different cereals. A lot of people will buy your vitamin D supplements. The natural way that our body gets it is through exposure to UVB lights. So you have 7-DHC, which is 7-dihydroxycortisol. And the UV ray B specifically, exposure from the sun converts that to D3. Okay, so pretty cool. Then that D3 is in the blood and it goes to the liver. In the liver, it's converted to 25 hydroxy vitamin D, or this is gonna be I don't have the names on here. Gosh, I'm gonna mess up. Cholecalciferol. Yeah. Anyway. So that's what's floating around in everybody's blood. And then when it's time, it's not active yet, and when it's time to do its thing, the kidneys need to activate it. So that metabolism from this 25-OHD3 to the active form, the 125, or the alpha 25, happens in the kidneys. Right? This is just kind of more of an elaborate thing. So you have 125-dihydroxy vitamin D, or calcitriol, and then now it's active and it can go do its thing in its target organs. Specifically for endo, it's in the intestines to absorb calcium. Okay. If I say so we know active. Okay, cool. What if this is the most circulating form of vitamin D in the blood? And I am worried that someone has a vitamin D deficiency. Which lab do I order? Would I order the active form or this 25? Yeah, it's 25, and that's people either forget that, and they'll order the wrong one often, but it's 25. That's what we want to know, right? That's what we're going to use for our labs. So I added this is just a summary based on questions I had last semester. But the 25, you're going to order. That's for screening vitamin D deficiency, which you'll do a lot. 36% of the U.S. population has a vitamin D deficiency. It also coexists anytime you have somebody with a parathyroid disorder, hypocalcium, like rickets, osteopenia, or other things. You're going to always screen and add a vitamin D. Some of recent fall, that's going to be more like your osteoporosis patients, liver failure. Those chronic diseases can also impact vitamin D. Okay. There's your range, insufficiency and deficiency. We'll talk about that more later on. You eventually won't be able to forget this. You're going to order it so many times. But there's your range. I don't expect you to memorize that right now, right? Just the diabetes criteria. That's the only range you can use. And then this 125 is active form. We're rarely going to order it. Okay. All right. Calcitonin essentially does the exact opposite effects of parathyroid hormone, or PTH. Okay. So calcium, it's a minor role overall. PTH is kind of the driver, but again, it's do the exact opposite of PTH. So if calcium levels get too high, it's going to go and do its thing to get fat homeostasis. So here's the pathway. We're going to have increased free calcium, decreased free calcium. What happens? Nice summary. Okay, so we're going to do it. So like this, here we go. We're going to do this. So we have a constant. Here's the normal homeostasis, 8.5 to 10.5. Everything is good. Oh, well, great. Calcium gets high. We have an imbalance and calcium is way too high, so that's going to stimulate calcitonin. Calcitonin is released from these parafollicular cells in the thyroid gland, and it's released in the blood, and it goes to the same organs too, the bones and the kidneys, and together they either reduce reabsorption, so we pee it out, and then the bones will hold on to that calcium and less reabsorption, and then we get back to homeostasis. Perfect. The opposite is true too. Calcium goes too low for whatever reasons. Okay, PTH is going to kick into gears. The parathyroid gland will release PTH into the bloodstream. It goes directly to our kidneys for reabsorption. Goes to the bones to stimulate release of that calcium from the bones, and then it doesn't directly impact reabsorption in the intestine, but it does that through the kidney. Okay, it all comes together. Go to full slide, and it's not too busy. So as long as you, again, lean back on this, and this will help you on the test, help you with studying, and help you see one, do one, teach one. This will help teach you back to yourself. Okay. Questions? If you don't get this later, let me know. But yeah, this is foundational. And now we're going to go into disorders. So first, hypercalcemia. Based on everything I said, what lab? So if I have someone come in and I do wellness labs and their calcium is high, what lab do you think I need to absolutely check to tell me what's going on? PTH, right? PTH drives is the overall driver of calcium metabolism. We're going to do PTH. It's that key determinator on where's the problem. So we use that PTH level to kind of guide me in what's the underlying issue here. Of course, we need to check vitamin D as well. We'll do some other electrolytes, but PTH is, yes, the winner. And again, that scenario I gave you, a lot of times people, especially with hypercalcemia, don't come in with complaints per se, and it's a lot of times it's incidental findings, but I will tell you how they'll present with these things. So there's a lot, we have 3 different etiologies, and they're all based on the PTH level. And we'll go through each of these, and you'll know which ones to care a little bit more about than the others. Okay? But they're all going to essentially present the same, potentially. They're going to have high calcium, right? That's the topic of this section. And so here's your ranges. Over 14 is very concerning for malignancy, okay? Underlying bolded, concerning. And that tracks with our other conditions, right? Especially when we're talking about testicular cancer with the excess beta HCG, or estradiol will be extremely high, or the hirsutism with all those androgens being excessively high, right? So it kind of tracks with what we've seen so far in endocrinology. Not everybody presents the same. So I might feel fine at 12. Another patient might feel horrible at 12. But essentially they still have characteristics as far as mild, moderate, and severe, as far as criteria is concerned. They have very non-specific variable issues from MSK, renal, lots of, review system questions would be necessary for these patients. And then the EKG is a short QT interval. You guys remember that? Do you have like a tool to remember that? Or do you just know? Okay, so I heard something and it's dumb. It's nice. I like the hirsutism one better. I can't take credit for this at all, and if you don't like it, I get it. But it's silly, and it can work for people in like pants and stuff like that. But it says like all Californians are short cuties. Stupid, right? But also if you have a lot of all that CAL, all that CA, all that calcium, short cuties. Maybe you can make it into like the oranges cuties too. But if that helps you, great. If it doesn't, I don't know. All right, so here are, have you guys heard of stones, bones, groans? Yeah, okay, yeah. So stones, bones, groans, moans, no tones. There's also at the top, some people will have it thrones due to the urine, so they get the stones and the thrones. but you'll see both out there. This is the same as it's been for years. This is like a high yield. Know this is associated with high calcium, okay? And so if I have excess calcium in the blood, kidney stones make sense, right? Lots of stones. You might have polyuria, thirst, metabolic acidosis, but I kind of underlined the key things that you'll see commonly. And then bones, you're gonna have bone pain, right? Just based on, and potentially more fractures and things like that. There's the osteotitis fibrosa cystica, or OFC. That's like if you've been in the state for a really long time. That's not good. You're replacing calcified bone with the cystic bone tumors. But again, not common, not underlined, but just awareness on that. Groans, right? This is abdominal pain, constipation, anorexia because they have pain. They are not moving, so they essentially don't want to eat as much. And then myalgia, joint pains, that sort of thing, so moans. And then overtones, it can affect cognition, mood, and that sort of thing. Feel okay with that? I will tell you, when you have someone, when I diagnose people with hyperparathyroidism, a lot of times are like, no, I feel better. So we'll talk about that. But honestly, the last guy I had who I diagnosed with this, he didn't have any of these symptoms, and then he went home and he's like, you know what, I am struggling with this, or I am struggling with this. So it might shine a light on something that they just thought was their normal, okay? We always ask these questions. So any questions on signs and symptoms? Makes sense? Okay. So the first etiology section is primary hyperparathyroidism. So it's overproduction of PTH, and if PTH is high, what's calcium going to do? If everything else is working down, like kidneys are working, bones are working, what? It's going to go up. These are like my favorite, right? PTH goes up, calcium goes up, indicates that it's a primary problem in the parathyroid cells. There's three subtopics that fall into this, with parathyroid adenoma being the most common. You know adenomas, right? In the past, they've been in the pituitary, so don't get that confused. This time, it's an adenoma in one of the parathyroid glands. Typically, it's only one. And then hyperplasia, we know that term, right? It's the overall increased enlargement of the glands, and then cancer. I think you guys, we already got this. So when calcium increases, this is the opposite question. When calcium increases, what do we expect PTH to do? Decrease, right? And it's not. So then that points us to it's a parathyroid problem, okay? And here's our reasoning. Still, if it's not clicking, or it's clicking now, and then when you go to study, you see these questions, you're like, what? Use your diagram. All right, so nice, pretty diagram. So you have an adenoma right here. Usually it's single, impacting one gland. Benign, and here is your regular parathyroid versus your doozy of a adenoma there. 80% of the time, when you have primary hyperparathyroidism, it's an adenoma. Most are mild or asymptomatic, and a good portion of them, 20%, will develop kidney stones, which makes sense there. Okay. So here's the discussion. You have asymptomatic, incidentally found elevated calcium versus a symptomatic patient. So what labs do we order? Obviously calcium. What are the others? We have incidental, yeah, PTH, what else? What other hormone did I spend like a while talking about? Vitamin D. Those. And then again, what do you expect them to be high or low, right? We expect calcium to be high, PTH to be high, and vitamin D likely low, but it depends. So here's your results. So again, this is, I hope, common sense. It kind of, physiology leads to the answers on the labs. So hypercalcemia, PTH is driving that hypercalcemia because of this adenoma, this unchecked release of PTH. Nobody wants PTH, but it's being released. And then vitamin D is typically low, but not always, so you need to check it. You can also consider a your 24-hour urine calcium, phosphate, magnesium, those electrolytes. If the top three are the most. Imaging. So imaging is not required to make this diagnosis, but you kind of understand why it's important, right? So you want to know which, there's 4 parathyroid glands, right? So I don't know where exactly the adenoma is. So you're not required to say, hey, I think you have hyperparathyroidism based on your labs. I'm going to send you to endocrinology potentially, especially if you're symptomatic. And then you can order an ultrasound or CT in the sense that it's helpful for that surgical candidate, right? I want to see what I'm dealing with. Typically, there's just one single adenoma, but this will help you. Most of the time, it's going to be an adenoma, but what if it's hyperplasia? That imaging can potentially help. The imaging options should make sense. Ultrasounds. If that doesn't work, like it doesn't work in 20-ish%, you can do a CT. For you, those are your options: ultrasound or CT. DEXA. So your dual energy X-ray absorptiometry. Nope, I messed that up. Anyway, DEXA scan you guys learned about in rats, but this is just evaluating bone density. So the minute you have someone diagnosed with hyperparathyroidism, they need to start getting DEXA scans, regardless of their age, even if they're a male. Okay, these people need to be evaluated with DEXA. You can do CTs because these people are what? Prone to what? Kidney stones, yes, you can do that. X-rays aren't required, but every now and then you might see some peripheral mineral changes in the bones. And once the calcium levels are back to homeostasis, typically it improves. And it's the bones of the distal digits. So the first one looks all messy. But look at the distal end of this guy, and this is 5 months after he had the adenoma removed. So. Okay, treatment. All patients, regardless if I'm struggling with my bones, groans, overtones, or I feel just fine. Everyone needs to have good hydration. Why? I mean, I want everyone to drink a lot of water anyway, but excess calcium, kidney stones, things like that. And constipation, right? If I drink more water, more fiber, it can kind of help things move through the colon a little bit better. So. Hydration and stay active, and need some vitamin D if deficient. So I added a stupid little slide last semester. So you have my dogs, we were at the Guadalupe Lake, so they're outside staying active and staying hydrated. Or this woman working out outside with her water bottle, okay? Mainstay treatment. I spend a little bit too much time on this because sometimes in the test brain you're like, oh yeah, I need to throw meds at him, I need to do this. But like, don't forget, cornerstone of treatment for everybody is that. Just like with diabetes, cornerstone of treatment is your therapeutic lifestyle. Okay. Now, we have a patient asymptomatic versus symptomatic. We're going to approach those a little bit differently. Not everybody needs surgery, specifically if they feel fine and they're not interested. You're going to do what? You're going to cut what out of the neck? No, thank you. I feel fine. Leave me alone. They still need to have hydration, stay active, and get their vitamin D, especially if it's deficient. And then you have to manage these. There's lots of monitoring now. Okay, so every 6 months, they need to check their calcium. Annually, they're going to need a 24-hour urine, kidney function, that DEXA scan, right? We made that diagnosis of hyperparathyroidism, so every 2 years, they're going to need a DEXA scan. Even though they're symptomatic, I'm still going to be like, hey, I'm going to explain the surgical options to them, and just verify that they're, feeling okay each time I see them, specifically with the stones, bones, groans. You guys. Now you have a symptomatic patient, someone who has lots of kidney stones, especially, or constipation, or etc. They have the option to get surgery, and that's the mainstay. There are medication options too, if they're not a good surgical candidate, but ultimately, in those roles, they usually do surgery. Now, you have patients who have that maybe they're mildly symptomatic, but their labs are really high, so their calcium is high in their urine. They're starting to have kidney issues with their creatinine levels. They're showing signs of osteoporosis. So these people, you're going to kind of be like encourage, maybe it's time to have surgery. I like this. Relative youth is under 50. That's still big. But patients younger, because they have a lot of life to live, you might want to fix it early. Okay, and you're a good surgical candidate. And then difficulty ensuring medical follow-up. Why is that important? Why would that drive you like, hey, you probably should just go see endocrine for surgery?
Because they don't want to have a neck.
Yeah, and look, you get to know these patients just like your diabetics. They have to come in and get screened, follow-up labs. So yeah, those are one. And then if this is just FYI, I don't think this is pants material, but pregnancy, if you have someone who's pregnant and you're diagnosed with hyperparathyroidism, you wouldn't do the surgery until into the second or trimester. Okay, questions on adenoma? This information makes the next ones go fairly quickly. So hyperplasia, right? Enlargement, overall enlargement of the glands. So just like with Graves' disease, when the thyroid was enlarged from hyperplasia, that was more autoimmune. Or the adrenal hyperplasia, when those organs are in that hyperplasia state, they usually spit out extra hormone, and that's what's happening. It's associated with our multiple endocrine neoplasias. Yay, MENs are back. I don't care if you remember the numbers this time. Clinical and lab presentation is the same as your adenoma. So again, that's where the imaging is not required for primary hyperthyroidism diagnosis, but the imaging is helpful for differentiating between the most common, which is adenoma, or the hyperplasia, or the least common, which is the cancer. Treatment for this is you're going to have a subtotal thyroidectomy. 3.5 glands are removed. How cool is that? All you need is just a little remnant left in your body to help manage the super important calcium metabolism. And you'll see later, it's sometimes hard to leave in here, and so they'll take that remnant and they'll put it other places in the body, in the forearm or in a spot in the neck, which is just cool. Again, because we want to prevent hypocalcemia. So here's your picture, hyperplasia. They're too big, too active, and that's a problem. And the last thing is cancer. Super rare, thankfully. And this is where you're going to see that calcium is super, super high. 14. It doesn't seem super high, but it is. It's 14 is bing, 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 malignancy, malignancy, malignancy. High PTH. It's trying to be like, hey, calm down. But the calcium is just getting is elevated. A lot of times these patients will have like a palpable mass, or through your review of systems that you're ready to do on Friday for your Montgomery, you catch that they have fever, do you have fever, chills, unattended weight loss, right, or other type of things. And then it also can be associated with MENs, and we're going to do surgery for that. And then maybe chemo and all the oncology things. Questions on that? All right, overall management of primary hyperparathyroidism, right? We know this. Everyone needs to stay active, stay hydrated, get their vitamin D. Surgical option for the adenoma if they're symptomatic, asymptomatic, we're monitoring. Understand surgical indications as well. Hyperplasia surgery, and for cancer, it's resection and all the referrals. That's like a summary. There are some medication options too that you can use. Again, for like maybe someone who's not a surgical candidate, they're symptomatic but not a surgical candidate. You can use bisphosphonates, which we'll talk about. I want you to focus more on those in osteoporosis, and then the calcium receptor activators also can help decrease parathyroid hormone. But again, maybe a farm or cards or something like that. Okay. So that's it for high PTH driving the high calcium. This next one is weird, and it's rare. You would have either a normal PTH or minimally high, but elevated calcium. And let's just look at the name for a second. So familial, so maybe it's genetic, right? Something like that. Hypocalciuria. So what is that? Low calcium where? In my urine. So I have low calcium in the urine, but I'm hypercalcemia. If everything is working as it's supposed to be, say there's no genetic issue, if I have high calcium in my blood, what do you think the kidneys are going to do as regards to the urine. What's the result? It's going to excrete it. So you'd expect if I have high calcium in my blood, my kidneys are going to respond to that level and kick out that excess calcium, right? We're going to excrete it. It's not happening here. That should flag, okay, what? But it's not happening, but it tells you kind of what to expect from these patients. So it's a genetic issue, it's benign, and it has to do with the defect in your calcium receptors. So they're just not working like they're supposed to be. And so that's why you have this hypercalcemia, but the body doesn't like recognize that it's like overt high calcium. So some people will have normal to slightly elevated PTH. And again, there's an issue with the receptors, and so that's why the urine is low calcium when you'd expect it to be high. These guys don't know there's an issue. It's super, super rare. They usually do just fine. There's no treatment for them. Essentially, you're going to do labs on this person. The calcium's high. You repeat it. You have the calcium. You do the PTH, the vitamin D, and the calcium. And the PTH is maybe normal or a little bit high. Then you go to your 24-hour urine because you're like, this isn't making sense. It's not my toxic hyperparathyroidism. And the urine calcium is low. And this is what you have. There's only one slide on this. It's like not super common. The name tells you what it is. If I have a question on it, it won't be too tricky, okay? But again, no treatment. They do just fine. All right, now we're going to suppress PTH. This also makes sense, right? So if calcium's high, we expect normally for the parathyroid glands are responding appropriately, right? So it's not. This tells me it's not a parathyroid issue. It's something else in the body because the parathyroid hormones are doing what they're supposed to do. I did a lot of bolding and underlining. I don't know if you guys like that or not, but I tried to because this one is a little tricky. But you can see the ones I care about the most on the right. But there's various things that cause again, it's issues somewhere else causing that high calcium outside the PTH. So we have to talk about cancers. It's always in the back of our minds, right, on our differential. And so when you have people with cancer and their tumors, those tumors do weird things, right? We learned that with SIADH and other things last block. But later in the cancer condition, some tumors, 10 to 20%, can produce something called PTH-related protein. So parathyroid-related protein, PTHRP. What do you think PTHRP does in the body? What is it? It's based on the name.
Does it act like
It's causing the excess calcium. My glands up here are suppressed. They're not doing it. So PTH, actual PTH hormone levels are low because it's not coming from here. It's coming from that tumor in the breast and the kidneys and the liver. Okay, so it's cancer causing more problems, and it releases PTHRP. Again, significant hypercalcemia, just like we had with the parathyroid cancer, right? It's not a parathyroid cancer, but it has significant high calcium. The difference is PTH is low. Indicates it's not a primary problem. It's not up here. Okay, so if my PTH is low, my calcium's crazy high, I need to do a PTHRP, and that will be high. And that tells me, okay, this is, most of the time these people already know they have cancer, but not always, okay? Unfortunately, not always. So, it acts on the bones a lot, causing, and other organs, but again, it's causing high calcium from its action on the bones. I don't expect you to know all these cancers. What do you think I care about? This is the term malignancy, just cancer, okay? But it can be all over. This, unfortunately, is a woman who had breast cancer, and just the spread. I don't know which tumor was causing the problem, but yeah, cancer is awful and ugly and all of these. So that's a picture of the bone. Okay, you have a 75-year-old female who was previously underwent a mastectomy for grade 3 node-positive breast cancer 6 years ago. Okay, so essentially a breast cancer patient had a mastectomy 6 years ago. She comes in either your primary care or the ER, and she doesn't feel well. she's struggling like fatigue-wise, and she's having this increasing back pain. So you do some imaging, do obviously physical exam, all of that, ask your review of systems, do your physical exam, right? Prepping for Friday. And then you do some imaging, and this, what do you guys think? Is that, I know Rats was a long time ago, but does that look like healthy bones? Yeah, there's like a lot of stuff. There's a lot. You also get labs on her, and her calcium is high. And then it's super high. It's over 14. Where does my brain go? Malignancy, right? Is it cancer of the parathyroid, or is there cancer somewhere else? Well, she had breast cancer, right? And so, unfortunately, it's messed. Not a good outcome for this patient as well. Okay. Other less sad factors for where you have suppressed PTH, where it's not a parathyroid issue, is immobilization. This is actually really uncommon, but when you don't use it, you're not moving and using it, maybe because you're inpatient or elderly, specifically with like spinal injuries, you can have this issue, where there's rapid bone turnover causing this high calcium outside of the PTH control. Okay? High bone turnover and thyrotoxicosis, so that's your Graves' disease, right? So it's, with your excess thyroid hormone in the blood can cause this. That's why many weeks ago we talked about thyroid dysfunction, specifically Graves, used sometimes to screen for osteoporosis, especially if they're not compliant on meds or they've had it for a while. And then the labs make sense, right? Serum calcium's high, super high in your malignancy patients. And you're like, wait, PTH is low, so it tells me what? Parathyroid glands are working appropriately. What else is causing this calcium to be high? Let me look for other things, okay? Or do they have a history of immobilization? Do they have thyroid dysfunction? Do they have cancer? You can also get it for people who just take way too much vitamin D. There's conditions that cause endogenous excess vitamin D. It's super, not as common, but there's that. And obviously, the labs should make sense. Big vitamin D problem. Why are thiazides underlined? What do thiazides do? It's a hypertension. It's a diuretic. But what relates to calcium? Yeah, it causes it. So do I want to give someone with hypercalcemia? Yeah, with thiazide. Just know your diuretics. So I talk about ACEs and ARBs a lot. Know your diuretics for pan stuff. Food diuretics, thiazides, and all that stuff. What the consequences are. Vitamin A intoxication, retinoids, so like people who are on Accutane for acne. Supposedly the ketogenic diet is an unknown or uncommon complication. Again, FYI, this was the exception of thiazides because they don't ever get that. And overall management for hypercalcemia. So we talked about overall management for hyperparathyroidism, but essentially, the main hydration, stay active, avoid immobilization is kind of a given with the staying active, but we're really hitting that hard, especially when it's not a parathyroid causing issue. We're going to give them vitamin D if they're deficient. We need to treat the underlying cause, right? Is it primary hyperparathyroidism? Is it this weird FHH where we don't have to do anything? Is it secondary to a malignancy, thyroid disease, or some kind of medication? Consider estrogen replacement therapy. So that, well, let's just do FYI. I don't want to, it's tempting, but I won't do that right now. Avoid large doses of thiazide diuretics, vitamin A, calcium-containing supplements. Okay. So you want to be in excess. You want the calcium levels to be right where they're supposed to be. That's your goal. And so again, focusing on the underlying treatment. We can stop here and come 5 till, and we'll switch gears to all these hypo. And okay, yesterday in clinical court we were doing the lab and I was talking crap about ortho and their stupid names, and I have a stupid name. Pseudo-hypoparathyroidism. Stupid, but there's less stupid names in this. We're going to talk about a stupid name thing, but you guys will get it. But again, all things causing hypocalcemia. We know calcium is important, right? We know it's tightly controlled by PTH. Vitamin D plays a role too with its absorption in the intestines. The most common cause of hypocalcemia is chronic kidney disease. Also, your elderly patients who are inside, they don't get outside a lot, they don't move a lot of time, or move around, they are at risk for vitamin D deficiency and also hypocalcemia. Okay. So this point at the bottom, I added, so in non-hospitalized patients, so US, your patients, your active duty population, that you screen and they have low vitamin D, most of them will have normal serum calcium levels, okay? We're gonna talk about the severe hypocalcemia, the rickets, the osteomalacia, the elderly, all of that. But we still check both together, okay? So still our main 3 labs. I just have to put that in. This next slide, let me see. So the next slide is FYI. This breaks down. So remember, we have free calcium. This ionized calcium is the active form, and then it's bound to albumin and other things. So when the most common cause of low total serum calcium is hypoalbuminemia. So that's again, it's because it's bound to the albumin and other proteins too. But that's FYI. And again, back in the day, like even before I was a PA, you used to have to do math to calculate the free ionized versus the total calcium, but we're not doing that. It's given to you, like if the calcium's off, a lot of times that free ionized calcium can be given to you often. All right, just like the last section with hypercalcemia, we have our etiologies. The bottom 2 are related to PTH. And the top one is just an increased loss of calcium, so that's independent of the parathyroid hormone. There's something going on in the kidneys, makes sense. Alcoholism or medication that's causing the loss of calcium. But before we go into each one, how do these people present? Right? This is paresthesia, myalgia, tingling. They're going to get tingling in their feet, their hands, and around their mouth. Confusion, irritability, seizures, and tetany. So could this be an emergency? Yeah, we haven't talked about emergency cases really. I mean, lots of cancer, but since DKA and HHS and hypocalcemia, or low glucose. So again, there is a mnemonic. It's that little CATS thing. Have you guys heard of CATS? I think last semester. It's not as common as the Bones Groans trick, but there is a mnemonic. I'm not a mnemonic person, but this one is very well known, and it's CATS go numb. So convulsions, arrhythmias, tetany, seizures, numbness in the hands, feet, around, and the mouth. So that's the CATS go numb for hypocalcemia. If I give you a patient with these symptoms, it's very different than hypercalcemia. Okay, so remember. Just like with all the stuff with Endo, I can't just tell you myalgias, right? Myalgias overlaps in both. I have to give you more confusion, tingling, right? Versus if it's hypercalcemia, I'm going to tell you stone, constipation, okay? Don't get those confused. Do your best not to. Luckily, they present very differently. If you like mnemonics, there you go. Additionally, you can have spasms in the muscles, laryngeal spasm or bronchospasm. Why is that scary? A laryngeal spasm. Why am I worried about that? Airway, right? Airway. So we need to maintain an airway early on someone who has low calcium. Okay? Don't wait. Be ready for that potentially an advanced airway. And then prolonged QT. You guys are already learning that, right? We have all Californians are short cuties versus the opposite here with the prolonged QT interval. The Trousseau's phenomenon, the shot skips, Schatzbeck sign. Can't talk today. Are you guys familiar with those? So one where you tap on the facial nerve and you'll get a spasm. And then the torsades is you with the blood pressure cuff. It has to be on there a while, but that'll cause a carpal spasm. Also, it is hypocalcemia, regardless of cause. So this shows the blood pressure cuff, and they're having the carpal spasm. But oh look, there's the transplant. So they had a parathyroid surgery. They moved the remnant into their forearm because it's like nice, good blood supply. It's easy to put in there during the OR. That likely is causing the hypocalcemia. Labs. What labs do we want? Whether it's incidental hypercalcemia or they come in with symptoms. They have myalgia. They have paresthesia. What labs do I want? Calcium, right? What else? PTH. Perfect, like that, and we'll add some magnesium in there too. But then my first three, that's what I care about the most, okay? So they're great, it's for spine. If you notice for a while we haven't had any like stimulation tests or order this and that. It's kind of nice. One benefit of this section. Magnesium is typically low in your alcoholics. And yeah. All right, so going into etiologies, first is nothing to do with PTH. It's a loss of calcium in the kidneys or meds or something else. I only have one slide on this, right? Chronic kidney disease is the most common cause of hypocalcemia. Would you expect vitamin D to be deficient? Right, that makes sense. Why? Because that active form of vitamin D is metabolized in the kidney. So if there's a kidney issue, it would make sense that we have less vitamin D doing its thing, reabsorbing calcium. Okay, so that kind of annoying chart at the very beginning we talked about vitamin D now kind of helps with this make sense. So there's low calcium and most likely low vitamin. Alcoholism, I already mentioned this, significant low magnesium, that inhibits PTH, and then calcium will go low. You can also see it with other conditions, besides not just alcoholism. I would say, I don't know if any of you guys have seen or like done labs on alcoholics. Their labs are kind of the craziest labs I've seen, and it's really sad. I've had one patient, she was like 20. Her labs, her blood alcohol level was insane, over 3. Anyway, she was small, and then I've had patients, their labs are crazy, and they always make me go and have to look, especially as CBC, and I have to be like, okay, this is what you need. So, but definitely the magnesium will be off, calcium will be off, and that's due to alcoholism. And then diuretic therapy. Which diuretic do you think would cause low calcium? Not thiazide, right? We already know that. More diuretic. So then we have, what do we have? So our loop diuretics can excrete calcium in the urine. And so indirectly you can use, they'll block the absorption of sodium, and indirectly you can lose calcium. Questions on that? No? Okay. All right, so now we go back to our feedback loop, and we have high PTH but low calcium. Well, PTH is high, what should happen? What should calcium do? PTH goes up, calcium should also go up, right? If it's not happening. Let's figure out what's going on. All right, so my annoying thing here. All right, so we have, this one is, it's pseudo-hypoparathyroidism. So if we look at the initial part of the name, it's pseudo, so it's not really, it's fake. Hypo is low, parathyroidism. Okay, so pseudo-hypoparathyroidism. So the labs make you think, oh, this patient probably has hypoparathyroidism because their calcium is low. But then we check the PTH, and the PTH is high, and it's like, oh wait, that's not normal. In true hypoparathyroidism, PTH would be low, and now it's high. Oh, it's that PHP. So initially what happens here, PTH is high, calcium's low, PTH high, indicates that the parathyroid is responding correctly. So the parathyroid is responding correctly to low calcium, but calcium is still low. So it's a PTH resistance. It's a defect in the kidneys. Okay. Let me see. So urine calcium is excretion is increased. So PTH. Okay. So let's go through this again. So I have low calcium. My parathyroid glands are doing what they're supposed to be, and they increase PTH because we need homeostasis and we need that calcium level between 8.5 and 10.5. There's an issue in the kidneys where there's a defect in the receptor, so it's not, PTH is going to the kidneys, but it doesn't connect, right? There's a receptor issue. So that means we lost our renal reabsorption and we lost our vitamin D reabsorption, right? But PTH receptors in the bones aren't affected. So we still have that bone reabsorption, right? So, which is good. It can, the bones try to help. But what happens if I'm hitting the bones over and over again? PTH. You can have some pathology within the bone, cystic lesions, fractures, and things like that. So it is associated, there's lots of conditions that can present with this PHP, but probably the most common is Albright's hereditary osteodystrophy, or AHO. Albright's hereditary osteodystrophy. So this is type A1, there's various types. It's a genetic issue with some like inherited gene things and proteins, and essentially they have these very classic physical appearance. They're short. They'll have developmental delay. You see the woman's face, it's kind of this like round faces, not quite, kind of like the Cushing's, but with the lack of the Cushing features. No redness. They're typically overweight or obese. So this is the one time I talk about obesity in this lecture, but short. And the big thing is their metacarpals. 3, 4, and 5 are short. Okay, so round faces, short, developmental delay. And here's what it would look like. You see, you can see it here is obvious, and then you can see it when they make the fist in the X-ray. Okay, so not everybody with PHP, it has Albright's, there's other things, but it's an association. Okay. Now, this one makes sense, potentially. It's more straight. Oh wait, no, we're not at this one yet. Okay, sorry. This one still makes sense. So we're in hypocalcemia. Calcemia is low and PTH is high, right? That tells me the parathyroids are doing what they're supposed to be, but we're not making a difference, and it's because of vitamin D deficiency is the problem, either from sunlight or adequate intake. Okay. And again, most patients with vitamin D insufficiency or deficiency that you will see have normal serum calcium levels. There are patients that have vitamin D resistance, but it's way less common than deficiency. Deficiency is much more common. And when I go to the next slide, it's all, you're like, oh, this is what this is. It's easy. So significant vitamin D deficiency as childhood is your rickets, right? You guys have heard of rickets. Do you think calcium is really important to development as a kid, as a pediatric, right? Or bone development, or long bones, or growth plates. We need strong bone mineralization, and these kiddos don't have it. And then it can happen as adults, and it's known as osteomyelitis. So again, this isn't your active duty person who's feeling tired and low energy, and they have low vitamin D, right? This is like significant true vitamin D deficiency, ongoing, and it's affecting the calcium. The calcium is low as well. So for adults, they're usually going to come in with some kind of bone pain or joint pain, and they'll have some specific, they're called looser lines, that'll show you. But again, rickets, osteomalacia, pediatric versus adults. Hypocalcemia due to significantly low vitamin D deficiency. So here's your skeletal deformities. most of the time you think of this like bowing or this significant varus, but you can also have valgus or knot pain. And again, delayed longitudinal growth plate issues. Really, that's all I need to know. There's more, but it's just like the bone stuff and growth, but longitudinal growth. And then for adults, they're going to be tired, like decreased endurance, muscle weakness, and bone pain. There is a picture here. I don't know, like if I saw this, it'd be like, would I think looser line or would I think fracture? But that's a picture of a looser line. Don't worry, I won't put that up. But that's indicating significant vitamin D deficiency, related hypocalcemia, and increased risk of fractures. So the labs for vitamin D deficiency, calcium is low or normal, but in rickets and osteomalacia, it's going to be low, most likely. Parathyroid is elevated, right? Because that calcium is not where it's supposed to be. It's trying to reach homeostasis. And then your vitamin D is low. Alk phosphate being high sometimes is that lab. I put a star by it. I don't know if I can't remember if it was in current or not. But it's like that, it's that one lab that kind of like, it's a classic lab finding to point you to osteomalacia or rickets. But imaging, like in adults and kids, we saw what the imaging looks like. But in addition to those x-rays, you could do DEXA scan would be important for these people, right? Low vitamin D, low calcium. I want to see what's going on with the bones. Not just an x-ray, but a co-potency as well. This one's FYI, resistance is possible, but it's less likely. It's a genetic thing. All right, moving on to low PTH and low calcium. Okay. So, if I have low PTH and if I have someone with low calcium and PTH is low, where do I think the problem is? The parathyroid, yeah. And we go to the pituitary all the time because we've been doing it forever, but it's the parathyroid. So low calcium and low PTH. So that low calcium level is due to the lack of PTH from the parathyroid hormones. And typically that's because maybe surgical damage. What kind of surgery do we do in the neck besides removing the parathyroid? Thyroid, right? So we're taking out the thyroid and maybe we do some damage to those parathyroids. Then there's some other conditions like autoimmune, maybe we're just born without it. Parathyroid glands, that's not super common. Or then maybe there's some alcoholism at play. They had some kind of neck cancer and they're underwent radiation and things like that. Or it just happens. So surgical damage, any neck surgery, not just the thyroid and parathyroid, but any other one. I have a picture, like coming up that why this should always be on the back of your mind. Any surgeon who does neck surgery, hypoparathyroidism is something they're monitoring for. But again, 25% of patients after they have the thyroidectomy will have hypoparathyroidism. Oh, and it can happen right away or it can happen later. That's normal. All right, what labs do I care about? Big surprise here. What labs? I just had thyroid surgery, or my patient just had thyroid surgery. What labs do I want to monitor to make sure they don't have hypoparathyroidism? Calcium, PTH, vitamin D, right? And then we're going to do all these other electrolytes too. We're going to look at the EKG. It's prolonged. We can use our EKGs to help us as well. Because I can get an EKG a lot faster than I can get labs in some places, right? So treatment, any questions on that? PTH is low, calcium is low. Okay. All right, so history of chronic hypocalcemia, any cause. We want to replace the calcium. We can. If they're stable, oral supplementation. Vitamin D, so again, most of the time they're going to be vitamin D deficient. Needs that good old sunlight, UVB, use in moderation. And then we want to treat, the goal is to keep the calcium in kind of more towards the low to low normal range. These patients, they're more prone to go from hypo to hyper really quickly. So when we control them, our goal is closer to that 8.5 than that 10.5, okay? We don't want to cause kidney stones and things like that. So again, get them in homeostasis, but a tighter, lower homeostasis level. So those patients with vitamin D deficiency or insufficiency, this is specifically related to vitamin D supplementation. So I added this slide based on questions. I don't have a test question for it, but this right here is what you will do in clinic. So you have an active, let's take the hypocalcemia out of it. You have an active duty member, male or female, you get a vitamin D on them and they're at 22. This is what you're going to recommend. Oral supplementation is 1,000 to 2,000 units a day. Repeat labs in 3 months. Some people can go as high as 5,000, even higher if you've had gastric bypass. Then you have someone who has vitamin D deficiency less than 20. We're taking out, not a rickets patient, not an osteomalacia patient. They're going to need 50,000 units once a week for 8 weeks. Then they go to the oral, and you're going to check labs. You'll have an autocorrect for this because you'll do it so much. In Colorado, there's a lot of sunshine, but I was to the point where I'm like, maybe just everyone has vitamin D or insufficiency. Maybe we should just put it in one. But again, that is a not testable, but like real life helpful thing. Okay, bringing it back to the lecture and hypocalcemia with vitamin D. You treat the vitamin D and the calcium, okay, but in that tight control. All right, we have our emergency acute case. We knew it was coming. Why? Because when calcium is low, what are the risks? Whether you use the CATS mnemonic or what? What are we worried about if calcium is low? Hypocalcemia, seizures, right? Confusion, coma, loss of my airway, right? So this is in that acute hypocalcemia. Medical emergency. Can be observed after a neck surgery.
Yeah.
For sure. And we're going to see, so they have surgery and we're going to monitor them for like tetany. What's another early sign that's not as scary, but an early sign that calcium's dropping? Tingling in the fingers, tingling in the mouth, right? So airway maintenance is so important, right? Because we know that as the tingling happens, the tetany is happening, that seizure is what I'm worried about, but don't forget about the airway. That laryngeospasm can be obviously very detrimental if we don't have an airway. So airway maintenance is a high priority, and then we need to treat this hypocalcemia. And we treat it when it's an emergency, we're going to do it IV, okay? And then once we get serum calcium in that 7 to 8.5, we can switch them to oral. Vitamin D deficiency is expected, so that's in there. And then if a lot of times they might need magnesium, so if it's indicated, we would treat that. Again, this is your picture. Who can find the parathyroid gland? Right? It's not a pretty picture. They're not purple in real life, right? So here's your thyroid lab, and here's one of your little baby parathyroid hormones, or parathyroid glands. Here are the glands. These just seem really small. This is the remnant, that's why. So here's your remnant. They're just confirming, did I actually get parathyroid remnant, or did I get some other tissue? And then here you can see where they implanted, and then post-op, months post-op. Super cool. They only need a little remnant. They take out 3.5. They like the brachioradialis because it's easy accessibility and it's easy to monitor because it's right here. They can also, sometimes they'll do the sternocleidomastoid, this SCM, they'll sometimes use that too, in that muscle, but a lot of times it's the brachioradialis. All right, so we're still in this acute phase, outpatient. We had their surgery, they were treated in the ER for, with the IV calcium, brought back up to 7.8 and switched to oral. So after that, we want to keep them in that sweet spot. Our calcium sweet spot post hypocalcemia is low normal. Okay? Minimizing the risks of renal stones and hypercalcemia. Yeah, how many times have I said vitamin D supplements? You guys are probably sick of that. Oh, you're gonna hear it all the time in clinic too. More than thyroid, maybe not. And then you're gonna monitor the calcium with blood and urine. Okay. All right, so that's it for the hyper and the hypos. We're gonna move on to osteoporosis and wrap up after that. So osteoporosis is loss of bone density, right? It's gonna happen as we get older, specifically in females. There's your breakout. There's loss of bone osteoid, reduces the integrity of the strength. So if I reduce that bone density and reduce the integrity of my bones, it makes sense that I'm more prone for fractures. 1.5 million fractures annually, so significant. Yeah. And 20% are 20% of patients over 50 will have vertebrae fractures. When we talk about osteoporosis, we talk about vertebrae fractures and hip fractures. Which do you think is more scary? Hip or vertebrae? Vertebrae sounds scary, like nobody, I don't want to fracture something like that, but it's hip. Hip. And then we'll go through the risk factors more specifically than that bullet there. So again, most common osteoporosis related fracture is in the spine, but hip fractures is where we have increased mortality, diminished quality of life. So you'll have an elderly little lady, usually Caucasian, but not always, who falls and breaks her hip, and she used to live on her own in her house, or maybe she's like more in that like assisted living. She breaks her hip, usually like her freedom, her ability to take care of herself significantly diminishes, and they don't always bounce back. So we want to prevent this if we can. So risk factors, there's the next slide, highlights all of them in current. There's a lot. But the main ones, and I think the main ones that are like pan-specific and life-specific are older age, over 65. Females, sorry guys, you can technically get osteoporosis when? Maybe from like some endocrine disorder like Klinefelter's, like excess corticosteroids, right? So you're not off them completely, but typically it's females that we're screening. And you're small, so not obese. The little old grandma who's like this, she needs to be screened for osteoporosis. People who are alcoholics, that makes sense, right? Because we just learned that alcoholics, it affects the magnesium, it affects the calcium, and therefore have a higher risk for osteoporosis. Smoking makes sense. Tobacco is a problem for all the things, right? Even the bones. I had no idea until I started teaching. The cola, like soda, I guess? I don't know. I just thought that's funny. Immobilization makes sense, or I'm not exercising a lot. That's why that's a huge part of your prevention. Hormone deficiency, so women who go through menopause and decide not, or aren't given or offered estrogen, that can cause a problem. And then obviously males with testosterone conditions be at risk. And the same, with that's deficiency and then excess, right? Our Cushing's, all of our adrenal stuff issues, our thyroid issues, they're also at risk. And then prolonged corticosteroids, right? Prolonged corticosteroids, you've learned that, and I touched that, talking about it again. You learned it in farm. Don't forget that. That is like a high yield thing. It seems like common sense, but it gets missed all the time. Okay? PPIs and many more meds. If you want to look at more meds, I don't even think there's a few more on here, but I don't go into all of them. Okay. Here's your DEXA scan. This is your bone mineral density measurement. So instead of an x-ray, you're going to do this. It's going to tell me what is my risk for fracture, when to start medications, and how, and when, prevention, we're talking to women about prevention for this much earlier than we even do the DEXA scan. But we start DEXA scan at 65, unless they have these significant risk factors. So I'm not doing a DEXA on a male unless maybe he has some hormonal deficiency or he has Klinefelter's, right? I'm not doing it on a female who's 59 because her sister had one, or because a lot of times I think they're better at it, but women's health nurse practitioners would always, I love them, I need them, but they would always do DEXA scans so early, start meds too early, and it's really frustrating. But again, follow the guidelines. And so you have a T-score and a Z-score. So the T-score is comparing you with healthy adult population, and the Z-score is evaluating with your peers. If you're 66, your Z-score is your peers, and your T-scores is the healthy adult population. Here's what they look like. Here is why the T-scores matter. So the T-score associates with the actual diagnosis, okay? It's not labs, it's not x-rays, it's not age, it's your DEXA scan. So T-score, I like the charts. There's that, I wrote that, and I like this a lot. So normal bone density is right here. And then osteopenia, or osteoporosis. True osteoporosis is when it's T-score of less than negative 2.5, and 2.5 to negative 1 is your osteopenia, and your pre-osteoporosis. So we get a DEXA scan of a 66-year-old female, or we have a 59-year-old female who was high risk for chronic corticosteroid use, or smoking, or alcoholism. And we do a DEXA scan and we get these labs, these values. Now you have to decide what to do with them. So first you have your categories, osteopenia. If they are negative 1 to negative 2.4, they're in this osteopenia, this like pre-osteoporosis phase. We typically don't do anything with these people except for prevention. Okay, calcium, vitamin D, and some lifestyle stuff. Unless there's something called a FRAX score. And it determines that this osteopenia patient is high risk for a hip fracture or a fracture somewhere else. So hip fracture risk of greater than 3% over the next 10 years, or just generalize any kind of fracture over the next 10 years, they have a risk of 20%. So again, it looks at based on, with the FRAX score, I have a slide for it. You put in all this information about your patient, and it'll tell you their risk. So their osteopenia with a high risk FRAX score, then we're going to talk about starting treatment in this osteopenia phase. Or if you have a patient who was on steroids for a long time, you're treating them when they're osteopenia. Doesn't matter. Okay, osteoporosis, we start treatment. That's a T-score. T-scores are important. You have to know these. T-score greater than negative 2.5 is osteoporosis, and then we're going to start treatment or discuss treatment options. Severe, I don't care if you know those ranges, but there's classifications for severe. If they're negative 2.5 with a fracture, or negative 3.5 T-score. Okay. Here's that FRAX score. So I would save it as a favorite on my computer. And sometimes they'll give it to you in the DEXA scan, but I would just plug it in. It's just like another tool to help you, especially when you have an osteopenia patient, of when should I start treatment? And again, it's that 10-year fracture risk and probability, just like the ASCVD risk, right, that you do in cards. It's that, but for bone fracture. When do I start? Labs. Okay, treatment and prevention overlap. So calcium and vitamin D supplements. Every little lady, I don't care if you're little or you're big, every woman should be on vitamin D and calcium. When you go to get your annual exams, your nurse practitioners who are great and we need them, they're going to push this all the time. This is the prevention for osteoporosis. You need to stop smoking. You should probably cut back on the alcohol. Exercise. Exercise is a cornerstone. They need to move. It increases bone mineral density, and what else? Muscle strength, right? It's going to help me if I slip. Like potentially catch myself a little bit better. Walking or resistance exercise. So resistance exercise helps with the spine. Walking helps with the spine and hip. And again, I push weight resistance for lots of reasons, but have these women move. Have you guys, I see it all the time at our soccer practices. You have these women in the weighted vests. Sure, I don't know if it works, but sure, add it. If they're moving and that adds resistance, that's fine. I've been talking, this is the third time I taught this, and I brought up the weighted, I bring up those weighted vests. And guess what on my Instagram feed? Women in weighted vests. I'm like, I'm not old enough yet. So I'm blaming it on this lecture, but maybe I am old enough. I don't know. Anyway, you'll see those. Fall prevention is key, right? So with different rugs, pathways, dogs are known to trick people, so we want to do what we can to prevent falls, because that hip fracture especially, but any kind of hip fracture. And then hormonal replacement. Estrogen is helpful in prevention but not treatment. So as people go through menopause, you'll discuss, are you a good candidate for estrogen or hormone replacement therapy? And that can help prevent osteoporosis, okay? But not treat it. So if I have osteoporosis, still give them estrogen, it's just not going to treat their osteoporosis. All right, indicated, we already know this, right? Osteoporosis, we need to do something about it. Osteopenia, we can do all this prevention stuff, but if the BRAC score tells me I need to, they're high risk, I'm going to start meds. Do you think I expect you to memorize this BRAC score thing? I don't. I just want you to know that it exists, okay? Because I don't memorize it. I plug in the information, boop, and then I get personalized. And it tells, if there's like a pretty chart, and it's of course red is bad, they need to get meds. All right, there are medications. Cornerstone, we have all the same prevention stuff, but there's specific medications that should not be too surprising to you. So calcium and vitamin D are part of prevention as well as treatment. All patients need to be on this. Obviously exercise, fall prevention, all of that. But your bisphosphonates, so your bisphosphonates, they'll inhibit osteoclast activity, reducing bone reabsorption and turnover, ideally strengthening and improving that bone mineral density. There's different medications work better on, like, say, the hip or the spine, but I just try to keep it simple and just put, just the drug class, okay? There's a table there. You can see that some of them are a pill and some are injections. Some are once a month, some are once a week. I don't know if it would be easier to remember once a month or once a week, but I think daily is a little bit easier, so you definitely have to have like a counselor patient on how you remember to take this every Saturday or every Monday. It is a first-line medication for osteoporosis, okay? First line. Big thing on this is that you do need to take a drug holiday after you've been on the medicine for 3 to 5 years. Side effects, of course, any medication has side effects. The big one, like that you tell all of your patients, is that you need to take it and sit upright. It can cause a lot of upper GI upset, and so much so that we can't give it to people with Barrett's esophagus, okay? There's additional side effects there, more for like the acute phase response, but again, nausea, gastric upset. Your receptor activator of nuclear factor kappa beta ligand for your wrinkles. This denosumab or Prolia is what I say all the time in clinics, but I'm trying denosumab. Denosumab is an option. It's a subcutaneous medicine. You only do it twice a year. It's a monoclonal antibody, and it, depending on which association you look at or which guideline you look at, it can, or I guess what your insurance covers, it can be first line or second line. I'm not going to trick you on that, right? Because I said right here, first line, so I'm kind of going to trick you. But for patients who have like Barrett's esophagus, or they have other kind of, they can't tolerate bisphosphonates for whatever reasons. Maybe they have an allergic reaction. Maybe I don't know, other things like that. You can give rankles and the inhibitors, and they are covered by insurance. This one doesn't require a holiday, but in fact they're like on it indefinitely. So you have to let the patients know. That's like we don't have like restrictions on when you stop. You don't. Parathyroid hormone receptor agonists. This is for your high-risk patients. I haven't prescribed this, but this is at high risk, that negative 3.5 T-score, multiple fractures. You can only be on it for 2 years, and then you get to switch to bisphosphonates. So, hormone replacement therapy prevention. SERMs prevention, not treatment. You can add it to help with prevention, but you can't treat it. And that is it for osteoporosis, hypercalcemia, hypocalcemia, all the things. We'll do some cases. Maybe some questions too, so that we don't have to, we'll do questions too, so we don't have to do it tomorrow. Okay, calcium is a 51-year-old male with hypertension and type 2 diabetes for 2 years. He is coming in for his 3-month follow-up. He's been taking metformin, 1,000 milligrams twice a day. He doesn't always take his medications as prescribed due to the side effects, GI stuff, right? We know that already. But mostly he just forgets. He just got to take the meds. Okay, at least he's honest. You do your labs. What do you see? High calcium. And then at the top, he's here for diabetes. He tells you, I'm not compliant with my metformin. So we see the diabetes up there too. But we're in our calcium lab, so this is your incidental elevated high calcium, right? So can we ignore this? The range is this range is 8.6 to 10.2. Can we ignore it? It's not even a full point, a full value higher. We can't. We need calcium to be tightly controlled, okay? So we cannot ignore this. It's not what we say, what did I write in my notes? Not non-statistical, it'll come to me. You don't say normal labs, unremarkable. This is not an unremarkable lab. This is something we have to follow. Okay, so there's our summary: glucose, A1C, calcium. We talk to him about type 2 diabetes, we adjust his meds, we do all that because we know how to do that. But what do we need to do? So we decide we need to do something about his calcium. What should we do next? Before I do labs, what should I ask him?
Diet?
Do you take calcium supplements? I like it. What else? What else do I ask him?
Diet?
Alcohol. I like it. What else? Either through my review assistants or HPI. Yeah. What review assistants or HPI? What do I ask? That's for hypo. What's for hyper? Stones, bones, moans, groans, thrones, all of the owns, right? We need to ask him that stuff. So, but you, sorry, we need to do anything about that. Here we go. What can cause elevated calcium? Oh man, there's lots of things, right? Parathyroid is the primary hypoparathyroidism, right? Adenoma, hyperplasia, that can cause it. That FHH, familial thing, that's not fun. That can cause it. And then alcoholism, thyroid disease, immobilization, chronic kidney disease, cancer, right? Are we concerned about cancer immediately at this time?
No.
No, because it's less than 14. All right, what next? That's, you guys already asked about symptoms, constipation, all of that. Now, he says, oh, I've had some kidney stones, and yeah, I'm constipated, but that's just, I thought that was normal. Now what do you want to do? Well, say you did a physical exam and it was normal.
Lab.
Now what do you want to do? Labs, right? What labs? PTH, let's do another calcium, and what else? Vitamin D. Probably some electrolytes, magnesium, phosphate, all of that stuff, but yeah. So you get your labs back, calcium is high again, PTH is high, vitamin D is insufficient, What should we consider next? Or what is highest on your differential? High PTH, high calcium. Yeah, primary. So where do you think the problem is? Yes, adenoma most of the time, or hyperplasia, or cancer, right? So what tool can we diagnose them with primary hyperparathyroidism? Yes, we can. What tool can we help? Yes, ultrasound. We need to do imaging, referrals, right? So let's see what happened with this guy. In July, we referred him to endocrinology. We ordered a DEXA scan because we made the diagnosis of primary hyperparathyroidism. We decided to go for an ultrasound instead of a CT. He gets his bone density. We rarely order DEXA scans on males, but he needs to have one. It's normal. Ultrasound in October, unremarkable. So at the top is your labs in July. And he gets into endo by October. They repeat the labs. They add a 24-hour urine calcium. What do you think of that? High, right? So that says the kidneys, that tells me the kidneys register, they have receptors that see that there's excess calcium in the blood and they're trying to fix it, they're trying to excrete it. And then there's a CT and it says something on the right side of the thyroid. I don't think any radiologist is going to say that. I don't even know why. It's funny. So there's something there. What is it? They'll tell you. They'll be better to you. All right. So what do you think the diagnosis is? An adenoma, right? Parathyroid adenoma. Is he symptomatic?
No.
Okay, yeah, a little bit. So what is the treatment for everybody who has primary hyperthyroidism? Yes, hydration. Think of the picture of the woman running outside or my dog's at the river, right? Hydration, exercise, sunlight, right? So he's symptomatic, so you're going to discuss surgery, or Amy's going to probably discuss surgery. What else about his case indicates this guy needs surgery? He's like, I don't care, I've been having kidney stones forever, and I'm fine with constipation, I'll do the water, I don't want surgery. What is the risk factor for this guy? The diabetes? And what about the diabetes? Is he good? Was he a compliant patient? No. And he admits it. I like that. I like you can admit it and say, like, I just forget. In Florida, I think I told you that, they have this attitude versus Colorado where like, hey, why do you stop your hypertension meds? Is it because of COVID? You don't know how to get them refilled? He's like, no, I just stop. No side effects to that? Why just stop? I don't know, they're like on beach time or something. Not everybody, but it was definitely a different trend. So Endocrine was concerned about his high calcium. He's in the 11s. He had symptoms. His age, which I apologize, I forgot his age. Maybe he's less, yeah. He's not great at managing his meds, right? He owns that. So they discussed the surgery to remove that adenoma. They do that in January. After surgery, I kind of feel a little bit better. So indicated that he might have had some more issues, more symptoms than he expected. Okay. All right. So I know I'm it. So we're gonna just go to questions. We don't have to do this in the lab, and then. You guys are good. So 5 minutes too. I didn't go crazy yet. So I'll post these today. I know you guys won't look at them. We have other things to focus on. There's OSCEs and cards, but they'll be in here. So, which of the following conditions causes hypercalcemia with a suppressed parathyroid hormone? Of course, in the test I'll have like maybe some cues. I might not tell you all of this stuff. I'll have like a patient scenario attached with this. But which of the following conditions cause high calcium, low parathyroid? So first, let's think about that. When calcium's high, what should parathyroid do? Be suppressed. So is the parathyroid working correctly? Okay. So what can we rule out? A. D. Yeah. Familial hypocalciuric hypercalcemia. That one might be on the board, but usually it's normal or high, so you can probably rule out that one. Vitamin D, 1,000 units a day. Is that excessive? It's not. It's not. It's It's just like a normal dose. So what do you think it is now?
E?
E. Yeah, it's E. It's uncommon, but it's possible. And here's the labs that go with it. Okay, which of the following conditions causes hypercalcemia? Oh, no, that's the same thing. This is why we were able to rule out the top 4. Okay. Now, what EKG abnormality is associated with hypocalcemia? C. Good job. Which of the following is the most common cause of primary hyperparathyroidism? Is that true that like if you don't know, you should just guess C? Maybe not in the Canvas because it's all like filtered and then changed. I was a B guesser. I'm like, yeah, maybe I don't know. I like to be. So. All right. A 75-year-old male has been a nursing home patient for the past 5 years. He complains of irritability, muscle cramps, tingling in his hands and feet occurring over the last few days. On physical exam, tap anterior to his earlobe, causing a facial spasm on that side. Which of the following lab results, third order question, would you most likely see in this patient? So, first off, let's talk. So he's 75 and in a nursing home. What do you think the calcium is? Low, right? Because he's in a nursing home. He doesn't get to, maybe he doesn't get outside. Maybe he's not exercising, getting all of that stuff. And then, what else did I give you? Signs and symptoms of what? Hyper or hypo? Hypo, right? The tingling, the irritability, all of that stuff. And then physical, there's even a physical exam. What's that shot? I'm going to say stick. Shot stick. Anyway, that sign. Okay, so knowing that, at least we know calcium is going to be low. So now, which way we go? So, elderly, the information's there. It's annoying, but when you study, it'll come. The information, he's elderly male in a nursing home with hypocalcemia. He hasn't recently had surgery. He's not undergone radiation. I would tell you all of that stuff. He doesn't have that risk. So now, which one do you think? Good job. And we need to screen him for vitamin D. So we're thinking vitamin D probably, well, elderly patients are at risk, and then also vitamin D deficiency for this guy. Here's the reasons. That's it.